So thank you very much. There are a lot of doctors joined me yesterday and in last week for Dubai. So I just came back early morning today. So it was wonderful experience for a whole week. And we have a lot of things to update you very quickly next 5 minutes without wasting the time. Number one, this lecture is not to scare you. But it's very important for new joiners or those who are not in UAE for them to know. You need to prepare well. Absolutely right? Because nowadays job saturation is little. I'm seeing in UAE market, I met almost more than 50 doctors in last 1 week in Dubai, and we had a good meetings. We had many pictures as well. We'll share you with you very shortly, right? So you need to be very concentrated and very updated for the things. It's not like a very easy exam the same way. It's not very difficult as well. But honestly speaking, you need to work properly for 2 months, those who are full timer, and 3 months, those who are not full timer, doing a job, doing something, right? Practicing, they need 3 months of good preparation. As you know, we provide everything online coaching, study material, subscriptions, everything. And another important things, we added two complete specialty. One is for homeopathic subscription. Completely our course is ready to go. Probably in 1 week we'll launch both the things, dental coaching and subscription, and homeopathy coaching and subscription. Fortunately, with all the support, we got a license renewal till 2028 to Dubai. So this is our license copy, right? This is like we got it just last week, and this is local doctors and team whom we met at this Dubai last week, right? And there are a lot more pictures as well, but just to cut short, right? I'll going to take 2 days hematology for you guys. Myself is Dr. Munjal. I'm hemato-oncologist and bone marrow transplant fellow. Dr. Arti, Dr. Mehdi, and Dr. Akanksha. Everyone knows her. Quite brilliant academic background. 10 plus year of academic teaching coaching experience. She is medical educator, academic strategist, content head, author, and she is an international faculty for many universities out of India, mainly Kazakhstan, Russia, and all. And she is also a guide for NEET PG and FMG exam. So wonderful academic and coaching experience. This is all our team, right? So Dr. Ramya is also joined our team. She is a consultant gynecologist and she is like in based in Dubai. Dr. Pooja is a dental head. Dr. Kainath is a homeopath head, and Pallavi everyone knows. Along with that, Dr. Meghna is operating from Dubai for data flow. Dr. Sonal Shah, she is head of this emergency medicine, practicing in reputed hospital in India. And Dr. Akanksha, you know, so she will be going to take over the platform in next 2 minutes. We have various packages. We have complete A to Z system for data flow. Anybody, any stuck up anywhere, right from beginning, account opening, exam booking, license renewal, right, getting eligibility letter, changing or performing the license from one to another, anything related with data flow A to Z, we can able to do it, and it's everything is done from Dubai. So Meghna will guide you, right? So, and this is the best, one of our best channel, right? I strongly recommend everyone to go for this channel. If not subscribe, then subscribe it, because if you see at least one video a day, it's equivalent to 50 MCQ by my sense, right? And regularly do the mock test. This is the only thing which will show you exactly where are you doing. I mean, standing. So we have excellent updated mock test subject wise. So you go and practice. Send me your score. Where are you stuck up, right? Why the score is low? Try to discuss, right? Get out of the comfort zone, right? So doing the mock test will only the test by which you get to know where are you standing and is it right time to go for the exam or not, right? Just with the 50% in mock test, 99% I don't advise and recommend you go for exam, right? Because there are high chances of failure, right? So if your mock test score is more than 70-75%, then it's reasonably good to go. So you check your own score. There are subject wise, everything is there. This is our discounted package. Lastly, one of the best packages, 40 hours, which supposed to be 1000 US dollar, will now for few days it's 350. Probably we are changing the module, so price may up. And that's it. So before I start my class, I'll hand over Dr. Akanksha. Right. So, madam, please take over the things, and I'll start after you. Thank you very much, ma'am.
Thank you so much, sir. Thank you for the wonderful guidance. I'm sure that it will be very helpful for all of us who are joining in. So, let us begin for today's class. Today's class basically is on infectious diseases. So, without wasting time, let us go ahead with our first question. So, do you want me to share my screen differently or this is fine?
No, no, I will make you the host, na, so it's
Yes,
problem.
sir.
Yes, ma'am. Can you change the slide?
Yes, all right. Okay, so the first question for today. Which of the following is the most sensitive test of CSF for neurosyphilis? Your options are VDRL, RPR, FTA, staining, dark field microscopy, or culture. Please post in your answers, everyone. Along with that, I would also like someone giving me inputs on what is syphilis or what are the types of syphilis, if you're knowing. Okay, Dr. Abby is saying it's E. Dr. Shafni is saying it's C. Okay. Dr. Mifra, Dr. Kavita. Okay. So we are getting there's confusion between option E and option C for all of us. Okay. So before going ahead with this question, I just asked you what is syphilis? What is the causative organism? Can anyone tell me what is the causative organism?
Treponema pallidum.
Yes, very good. So syphilis is basically disease, and the causative organism for this is going to be Treponema pallidum. Now, syphilis is basically classified by various types. Either it can be acquired syphilis, which can be your primary and secondary, or it can be your late syphilis also, which is basically a sexual infection, but it is a latent one. Then it can be a congenital, or sometimes we also classify syphilis based on the sites and the syndromes. So just like this, I have mentioned here, it is neurosyphilis. Along with neurosyphilis, other sites we have is ocular syphilis and otosyphilis. Okay, so the correct answer for this question is FTA. So let us see why answer is FTA. So FTA means what? It is a fluorescent treponemal antibody, the test of choice with the CSF, which excludes your neurosyphilis. So basically, it is having 100% sensitivity for your CSF analysis. Okay. So whenever we are trying to consider neurosyphilis, always keep it in mind that FTA is going to be the test of choice. Why? Because it is having 100% sensitivity. Now, when we talk about syphilis, as I was telling you, syphilis can be classified in the ways of either your primary or your secondary. If not, then it is based on your organ or the organs like the sites involved. So it is neuro, it is auto, and give me a minute. There's some problem with my net. 1 minute. Okay, sorry. So we were talking about neurosyphilis, otosyphilis, and ocular syphilis. So there are three types which are based on the organs. Then there is primary or secondary. Also, there is something that you call it as early congenital or late congenital. So congenital type of syphilis is also important. You have to remember what are the types of syphilis as well as the causative organism. Everyone knows it is going to be Treponema pallidum. Now, whenever the word syphilis comes or whenever the word syphilis strikes in, you should always have in mind either what is the type, second, what will be the sign and symptoms or what stage is it in, and third will be penicillin, obviously. Now, let us see what exactly will be the treatment for the syphilis. Okay, so whenever we are talking about diagnostic test, these tests for syphilis, what we are doing, that is your fluorescent antibodies, also VDRL, RPR, dark field, and culture. So whenever we are talking the highest sensitivity, see this table. This is very important. Here, the highest sensitivity is for your fluorescent antibodies, which is going to be your 100% sensitivity. Specificity, not much, but sensitivity is the highest. That's why we prefer this. VDRL, it is highly specific. Keep this in mind. In exam, if they're asking you highest sensitive test, it has to be FTA. If it is CSF VDRL, it is the most specific test. Can anyone elaborate me what is sensitivity and specificity? Yes, please.
Best to rule out and
Sensitivity is
best to
the
confirm.
Yes, very good. So what does sensitivity exactly means?
Mm,
What
ability
will
of a
you
test
use?
to ability of a test to detect the
True
cause
positive.
to a percentage.
if the test is negative, like suppose if the sensitive test is negative, then definitely it cannot be positive.
Okay. So is a sensitive test always truly positive?
No.
No,
Okay.
like in case
And
of
okay, so basically, a sensitive test, it is the test which is going to help us to identify the true positives. Always keep this in mind. So, sensitive means true positives. Okay. And specific means what? Identify the true negatives. This is very, what you say, confusing thing. So whenever I say that a test is sensitive, that means it is going to show you what is the exact number of true positives. And if the test is specific, that means we can see the exact number of truly negative test. So sensitivity is what? It is for detecting the presence of the disease. Okay. So if the disease is present, then the test is going to be sensitive. But if the disease is absent, to rule out absence is specificity. I hope this is clear now. Any doubts about sensitivity and specificity? Because this is also one of the questions that they ask you in the exam. So if we want to
Yes,
see
ma'am.
whether the test is exactly positive, as mean the disease is there or not currently, then we have to see the sensitive test. But we have to rule out if the disease is present or it is absent. But ruling out the absence is done by specificity. And sensitivity means the disease is presently there. Okay. Then coming for RPR, RPR is actually not validated for CSF, and there is also sometimes we can have it RPR in serum screening for the blood, but not valid for CSF. Dark field microscopy, yes, it is one of the commonest things that we do for Treponema pallidum, but we can only have the lesion dark field microbioscopy, not for all the generalized CSF samples. And if we talk about the culture, CSF culture is actually not possible in case of your sensitivity or checking for your syphilis. So therefore, we do not recommend CSF cultures. Okay. So the correct answer for this question is your fluorescent antibodies. Now, as we know that neurosyphilis is what? It is the infection of the central nervous system by the Treponema pallidum. Okay, then it can occur at any stage of syphilis, whether it is early, late, but not only tertiary. That means even if the syphilis is in the acute phase, that is the initial phase, this time also there can be neurosyphilis. Okay, now clinical types, that is the early neurosyphilis, it is going to show you symptoms or the presentation is going to be there in a very shorter period, maybe in 2 weeks, maybe in 3 weeks, or sometimes it can be seen during years also. So it can be, the duration can be of the weeks or it can be years. And sometimes it is also asymptomatic CSF abnormalities is seen during your neurosyphilis. Now, when we say that it is a syphilitic meningitis means what we have already seen types of meningitis in our last class. But now when we are talking about syphilitic meningitis, what all things is going to happen? There is going to be headache, there is neck stiffness, that is your Kernick sign will be positive. Cranial neuropathies will be there, especially the involvement of cranial nerve number 7 and number 8. That is your facial nerve. And which nerve is the number 8? Anyone? Anyone would like to tell me what is cranial nerve number 8?
Oculomotor.
Vestibulocochlear.
Okay.
Oculomotor. No, sorry.
Oculomotor, no.
Eight.
This is the third one, yeah. Vestibulocochlear is the eighth one.
Okay. And what is cranial nerve number 6?
Vagus. No.
No.
Abduction.
Cranial nerve
Abduction?
number 6?
Abduction.
Abduction.
Okay.
Abductions. No?
Okay, fine. Good. So vestibulocochlear as well as the facial would be here. That is the involvement. Then coming for the late neurosyphilis, what we call it, it is going to be seen for years or maybe decades. For example, if he or she had syphilis 10 years ago, after that, what is happening? After that, the patient is fine. But suddenly, after 10 to 15 years, the patient starts developing your neurosyphilis. That is, it is the late type of neurosyphilis. Then you have general paralysis or tabes dorsalis. These are the that you will see in neurosyphilis. General paralysis, a total paralytic kind of a thing where you will also have neuropsychiatric decline, dementia, personality changes. Tabes dorsalis, this word is always seen. What is tabes dorsalis? It is the posterior column degeneration. That means the patient, he is going to have the sensory and the reflexes are not going to work well. So sensory ataxia and areflexia. Also, there is going to be Charcot joint, that is the swollen joints. Generally, Charcot joints are also seen in diabetic patients. So therefore, there will be Charcot joint, sensory ataxia, lightning pains. All this is going to come under tabes dorsalis as well. Now, also, the specific syphilis, that will be Argyll Robertson pupil and ocular syphilis. So ocular syphilis at times is also going to be treated same ways like your neurosyphilis. See, basically ear, your eye and your brain. So eye, ear and brain. These three things, they are very well connected to each other. So whenever a neurosyphilis sets in, it is also going to cause you ocular syphilis and otosyphilis as well. So therefore, whenever you're talking about neurosyphilis, the treatment will be the same for all the three that we say as per the organs. Now, what is the treatment? As I told you, immediately whenever you see syphilis, first thing should come in mind is your penicillin. So, aqueous crystalline penicillin G, which is always given with IV route, and what? And you have to do to 4 million units IV every 4 hours. Okay. So basically 6 doses will be going in and a continuous IV infusion. Either of it. Either you give it just like every 4 hours, that is 6 doses, or you give it in a continuous infusion of the IV. In the practice, we do it for 12 to 15 days, but 10 to 14 days is the basic time period. Patient gets better immediately after the 5th day, but still we have to continue the treatment for 10 to 14 days.
Excuse me, ma'am.
Yes.
Your voice keeps breaking. We can't hear you.
Am I audible now?
Yeah.
Okay.
At times it becomes fading, ma'am.
Okay. Sorry. Some issue with the net, but okay, let me still go ahead. So I was talking about what? I was talking about till where have you heard me? Till benzathine penicillin?
No.
Okay.
Duration.
Okay, duration. So I was telling you that the patient gets better immediately after the 5 to 7 days of treatment. But even if there is improvement in the patient, you have to still continue the drug for 10 to 14 days. Recommendation, personal recommendation in clinical practice, I would suggest it should be done for 14 days. Okay. Second, if there is a option available for getting your benzathine penicillin G. You can give 2.4 million units IM every weekly for 1 to 3 doses after your IV therapy. That is your follow-up routine. Okay. So what will you do in follow-up routine? You're going to give 1, 2, 3 doses every week, but it is going to be intramuscular with benzathine penicillin G. If there is a penicillin allergy for a patient, some people are sensitized to penicillin, and if there is no desensitization is not available, what will be the alternative drug of choice? It has to be your ceftriaxone. As we have seen, ceftriaxone is also the drug of choice for meningitis, but the dose is different. Here also we have ceftriaxone, but the dose for ceftriaxone is different. The dose here is 2 gram IV or IM daily for 10 to 14 days. Okay. Now, in considering syphilis and penicillin, so when we talk about syphilis with penicillin, there is something important that you should be knowing, that is your Harris-Herxheimer reaction. When you talk about your Harris-Herxheimer reaction, what is it going to be? It is going to be a reddish rash all over the body. There is going to be fever, there is going to be chills, there are going to be rashes. The patient will come to you with red rashes all over the body with fever, chills and body pain. That is myalgia. Here, what is the treatment that you're supposed to be doing? You have to give NSAIDs, but keep in mind, do not stop the antibiotics, because even if the patient is undergoing such reaction, it is obvious the patient is going to get better later. Just symptomatically treat this inflammatory reaction, because it is an immune response of the body which is causing this Harris-Herxheimer reaction. Okay. Now, whenever we talk about this, we have to monitor what? We have to monitor the VDRL. We have to monitor the VDRL titers. And whenever the titers are falling more than 4 folds, that means the patient is recovering. If the titer is not falling below 4 folds, the patient is not recovering. Something is wrong. You need to reanalyze your diagnostic methods. All right. Okay. So, along with syphilis, there is also another type of sexually transmitted diseases, especially in the exam that they ask you. If they're asking you about HSV, okay. So, if it is herpes simplex, what will be the lesion? The lesion will be painful, and it has to be vesicles with ulcers. I have a slide ahead. I'll show you the lesions there. Then, if it is syphilis, it is a painless lesion. Painless lesion, or you can also call it as a chancre formation. Everyone is very well aware with what is a chancre. We'll see it ahead in the slide. So whenever there is a painless lesion, think of syphilis. If it is a painful lesion, don't think of syphilis ever. Always think for HSV, okay, or a chancroid or a LGV in a chronic stage. When we talk about a chancroid, it is again a painful lesion and it looks like a ragged ulcer. If it is LGV, it is painless early, but later on in a chronic stage, this LGV becomes a painful lesion. Okay, so see, this is the lesion. This is your chancre. This is your HSV. This is your chancre. This is your LGV. And this one is not chancroid. This is again a different. Okay, so this was your lesions. This is also your HSV. Why is it not writing? Okay, this is also HSV. There is not one image that I was seeing. Okay. But keep in mind, see this is the pustular vesicular formation. This is going to be very painful. And one more thing, it is going to be in a typical area, that is going to be in like it on the trunk, most common region. It is on the trunk, on the abdomen, on the neck. HSV is going to be seen. Then here is your LGV. LGV initially it is not painful, but later on, whenever there is a lymph node involvement, the infection is getting spread here and there. It is going to be your LGV, sorry. Then this is your chancre. Chancre is going to be on the tip of the penis generally, but it is a painless lesion. This is never going to pain. The margins are very clear cut. There is no discharge. There's nothing. It's just a simple lesion. And whenever you see this, always think of syphilis. Okay, just for your exam, what you should be knowing, painful vesicles, it has to be HSV with burning, tingling, prodromal symptoms, and there is a recurrence history, especially seen in diabetes mellitus patients. If the lesion is clean, painless, with non-tender lymph nodes, it can be syphilis. If it is a ragged, dirty, bubulous ulcerous type of a thing, it can be your chancroid. Small paleness ulcers with painful later on, it can cause the buboes is what? It is a elevation. Buboes means elevation. So whenever you see elevations which become painful later on, it has to be your LGV. Then if it is a beefy red ulcer, it is granuloma inguinale. Okay. All right. So was syphilis clear for all of you? Yes. Was syphilis clear?
Yes, ma'am.
Can anyone tell me what is the dose for treating neurosyphilis? If it is a penicillin allergic patient, what will you do?
Ceftriaxone, madam. 2 gram IVR IM.
Okay. For how many days?
10 to 14 days.
Okay. Very good.
Daily for today.
Okay. And no one asked me this question. Okay. So because we have seen what if the person is taking penicillin, first we give IV for 10-14 days. After that, we ask for IM. So will you do the same thing with ceftriaxone? Yes or no? Maintenance dose will be given with ceftriaxone as well or not?
No,
Yes, Dr. Piyush?
yes, no, because patient is already allergic to penicillin. That's why we are giving ceftriaxone.
Okay, no. But will you give the maintenance dose of ceftriaxone as well later on? Just like it
Yes.
was crystalline penicillin and benzathine penicillin. Now here only ceftriaxone is there. So here also you should ask the patient for follow-up, and 1 to 3 weeks, what will you be doing? You will be giving IM ceftriaxone 2 grams. Okay, clear? So same thing should be followed here as well. Okay, so tell me what nerves are affected in neurosyphilis, cranial nerves, especially which ones?
7 and 8,
And
madam.
it
Okay,
7 and 8.
very
Facial
good.
and
Fine. And if it is a painful ulcer with your vesicle formation, what is it?
HSV.
HSV.
This way.
HSV.
Perfect. If it is initially painless, but later on it becomes painful and bubonous, what is it?
LGV.
LGL.
LGV.
LGL.
Okay, perfect. All right. So let us move on for the next question now. A 36-year-old, generally healthy woman comes to the office with urinary frequency and burning. The urinalysis shows more than 50 WBC per high power field. What is the most appropriate treatment in the management? Now, will you give nitrofurantoin for 3 days, nitrofurantoin for 7 days, urine culture, USG of the urinary system, and a CT scan of the urinary system? Please post your answers. Okay, so I have got the answers. Everyone's saying A. Okay. Okay. Someone's saying C. Dr. Justin. Dr. Justin, can you elaborate? Why would you like to do a urine culture? Can I get some input from you, please?
To know the sensitivity so that we can get the correct antibiotics later on for this.
Okay. But for the urine culture, it will take 3 days, right?
Yeah.
So for 3 days, what should be your approach to the patient?
Or
Will
we
you
can give
wait
him,
without doing anything for 3 days, or what will you do?
so we will have to give something. So I think we can give maybe a urine alkalizer and even nitrofurantoin for 3 days.
Okay, fine. So you have a confusion in answer A and answer C.
Yeah, probably that. Yeah.
Okay. Yes, Dr. Anisha is saying B. Why, Dr. Anisha, you want to give nitrofurantoin for 7 days?
Because this patient has symptomatic UTI
Hmm.
and WBC 50 WBCs are positive in the extent. So she
Okay.
needs antibiotic for 7 days.
Okay. Perfect. So if we are thinking of antibiotics for 7 days, the correct answer for this question is nitrofurantoin for 7 days. Okay. But now, before I go ahead, I would like to ask whether this is a complicated cystitis or an uncomplicated cystitis. What exactly it is?
We'll find out on ultrasound.
Okay, but with clinical symptoms, if I want to say it is complicated or uncomplicated, when do we call it as a complicated and when do we call it as a uncomplicated? This is very important considering our exam.
It will look like just uncomplicated.
It's
Okay.
uncomplicated.
See, uncomplicated, there are only two symptoms. That is increase urine frequency and burning. Okay. So when we say it is uncomplicated, urinary frequency increases and burning is there, just like apparently healthy women. So what they're saying, generally healthy women with only two complaints. So this is a uncomplicated type. Now coming to the complicated, along with this urinary frequency and burning, you will also be having fever and chills. Fever and chills will also be there. Also, there will be other symptoms just like any systemic involvement or any systemic symptoms, you can call it as. So basically, any systemic involvement with your fever, your chills, and urinary frequency with burning, this can be a complicated cystitis. All right. Now let us move ahead with our answers. First here, what is it? How do we do? It is a 36-year-old woman, healthy. This urine frequency is only increased. So it is basically an uncomplicated acute cystitis. Now here, what is the treatment? We have to give empirical treatment, then investigate, and then imaging. So what exactly we are going to do? We are going to start the treatment first. So the first line drug for an uncomplicated cystitis in a female has to be nitrofurantoin. Okay, it has to be nitrofurantoin. If not nitrofurantoin, you can go for fosfomycin. And if fosfomycin is also not there, then you can go for a trimethoprim and sulfamethoxazole. That is your TMP SMX. Okay, this combination also you can give. It was a very older drug, but these days again people are started using it. But it can show resistance at times. So first line, first preference, nitrofurantoin. Second preference, fosfomycin. And third is your TMP SMX. Okay. Now, when we talk about clinical conditions, this is all about your urinary tract infections. Then just keep this table very handy to you and remember this always. So, uncomplicated cystitis in female. So, you can give nitrofurantoid for 5 days or TMP SMX for 3 days. In our options, we had 3 days and 7 days. So, always go with the one which is ahead of it. Don't go with something which is shorter. Okay, so just like if the question comes to you, which we had here, it was 3 days and 7 days. There was no 5 days option. Always go ahead with 7 days option. Okay, so it is uncomplicated 5 days of nitrofurantoin, or we can have your trimethoprim sulfamethoxazole. Okay, then complicated cystitis in a female. What will you do? You will do the same, but the nitrofurantoin dosage has to be 7 to 14 days. Oral cephalosporins can also be given, or you can give TMP SMX again. Male cystitis is always complicated. Male cystitis is never the uncomplicated one because the male cystitis pattern, burning, micturition, frequency in urination always comes with fever. It is never that it is not going to be just burning micturition. If it is only burning micturition in a male, you can just give the urine alkalizers. That would be sufficient. Here, the same drug will be given again for 7 to 14 days. Also, we can try out fluoroquinolones. So, fluoroquinolones, okay, out of this thing, just one question. What is the most common complication of fluoroquinolones in athletes or young adults? Last time we had seen in this class. Can anyone tell me?
Tendon rupture.
Rupture of
Okay.
Tendon rupture.
Yes, very good, very good. So we have fluoroquinolones like ciprofloxacin, which can be given for male cystitis or your TMP SMX. Pyelonephritis, OPD basis, same treatment you give. And fluoroquinolone alone is preferred for your pyelonephritis. If it is a pyelonephritis IPD patient, okay, what will you do? You will give 10 to 14 days IV and then switch on to oral. So IV will be for 7 days and oral will be for 7 days. This will be ideally there. Then you have ceftriaxone. It can be either orally given, also your fluoroquinolone or TMP would be there. But fluoroquinolones, generally, excluding your cystitis in a female, they are the first line drugs where we use it. In your pyelonephritis maybe, in your bacterial prostatitis maybe, or in your catheter associated UTI also. But catheter associated UTI always go with the culture results. Only remember, culture is mandatory in case of catheter associated UTIs and nowhere else in a OPD basis patient. Okay. Then you have acute bacterial prostatitis. Again, the same thing. Catheter UTI, as I told you, that culture guidance is always important. Pregnancy cystitis. So pregnancy cystitis, nitrofurantoin sometimes can cause some teratogenic damage, or generally we do not try for nitrofurantoin in pregnancy. The woman tries to feel very much nauseatic. There is lethargy, lot of complications. So we try to give cephalexin or amoxiclav. Cephalexin and amoxiclav are very well safer in pregnancy-related cystitis or pregnancy-related pyelonephritis. You give IV cephalosporins. So cephalosporins are always safer in case of pregnancy. If it is urosepsis, then what will be there? Any broad spectrum IV antibiotic. Can anyone tell me two names of a broad spectrum IV antibiotic generally used in ICUs?
Meropenem.
Okay, very good. So, meropenem and piperacillin tazobactam. Okay. And if it is a very higher sort of infection, you can also try it for colistin as well. Okay. So that was all about your UTI. This was sufficient about understanding what is a complicated and what is a uncomplicated UTI and what will be the drug of choice. If we have to summarize it, there are just three things. Always first see whether it is a complicated or uncomplicated. Whenever you find it out it is a complicated, go for your fluoroquinolones, trimethoprim, sulfamethoxazole, or you can try out for nitrofurantoin. But if it is uncomplicated, go ahead with a nitrofurantoin option, generally 5 days. Okay, as simple as that, just to sum it up. And if it is a catheter associated UTI, go for your culture. Okay, and if it is a urosepsis, then always give a broad spectrum empirical therapy. All right, so this was all about your UTI part. Okay, another question, same type. What is the single biggest difference between the treatment of prostatitis and cystitis in a 60-year-old man? Okay, so they are asking us difference between prostatitis and cystitis. So what is it? Either it is a causative organism, duration of therapy, use of urinalysis, efficiency of TMP SMX, or your efficiency of IV medications. Yes, post your answers, please.
B.
Okay. Yes, everyone. Basically, can anyone tell me what are the types of prostatitis, or what is prostatitis exactly? If you consider DHA exam, prostatitis is a very important topic that they always ask questions on. Okay, let me see what are the answers everyone's giving. Okay, B. Fine. Fair enough. This is a correct answer. Okay. So when we talk about a prostatitis, what is exactly the prostatitis? Prostatitis means it is the infection of your prostate gland with urinary symptoms, with or without pelvic pain and systemic infection. So basically, whenever you talk about prostatitis, keep these things in mind. So if it is a prostatitis, there has to be your pelvic pain and your urinary symptoms. These two things has to be there. but pelvic pain can be there or cannot be there. But urinary symptoms have to be there if it is a prostatitis. Okay. Now this prostatitis and as well as your systemic infection. Now, when we talk about this prostatitis, generally what it is divided into 4 types. In your exam, they ask you only type 1 or type 2. But when we talk here, it is going to be about 1, type 2, type 3 and type 4. Type 1 is what? Type 1 is your acute bacterial. Type 2 is what? Your chronic bacterial. Type 3 is your pelvic pain prostatitis. Okay. And type 4 is asymptomatic, but there is inflammation. So type 4 is asymptomatic, but inflammation. So these are the 4 types of prostatitis that you should be knowing. Mainly related for your exam is type 1 and type 2. Okay. So if it is the cystitis, then what is there? The infection is limited to the bladder lumen and the mucosa. Antibiotics easily reach out to the therapeutic concentration. Therefore, a short course for 5 days works in cystitis. But if it is a prostatitis, your duration of the therapy, which was a right answer, it has to be for a longer duration, just like it has to be for 2 to 4 weeks. Why? Because it requires your lipophilic drugs and longer therapy duration. Okay. So why I'll have the next slide here. When I talk about lipophilic drugs, that means the drugs which are going to reach to the prostate exactly, there is very much efficiency differentiation between the class of the drugs. And in your exam, they always ask you which drugs have better penetration, which drugs have poor penetration. This also you should be knowing it. Now, just see this. If it is an acute bacterial prostatitis or a chronic bacterial prostatitis, what is the difference? Acute, sudden, chronic one, there is an insidious onset or it is coming recurrent episodes. The frequency of this is 1 episode every 2 months. Then we call it as it is a chronic bacterial prostatitis. Fever is usually high grade, yes, because it is acute one. Toxic look, yes, it is going to be there, but generally it is not present in your chronic bacterial prostatitis. Also in class 4, the same thing is going to happen, that the patient is not going to have any toxic look. The fever is also going to be present. Why? Because our class 4 prostatitis is asymptomatic inflammatory prostatitis. So therefore, the same things are going to be happening here as well. Now coming to dysuria. Dysuria, what is going to be there? It is going to be seen in acute types, but it is not seen in the chronic types, or sometimes it can be at a very mild level. Perineal pain, as we have seen, that prostatitis can be with pelvic pain or cannot be. So perineal pain is very marked here. Also in class 3, it is going to be very marked, but here it is going to be dull or it is going to be rare. Then you have DRE prostate. How does this prostate look like? It looks boggy, it is tender, it is warm to touch. But generally in chronic prostatitis, the prostate, whenever you touch, it is only going to have mild tenderness, and or sometimes it is asymptomatic, that there is no pain. Always remember, they ask you this question. Prostatic massage is not indicated in acute stage. Acute bacterial prostatitis, never give a prostatic massage. This is only used in your chronic stages and used for your diagnostic symptoms. Also, WBC count, it is going to be higher. Urine culture can be positive in prostatitis because the infection is also around the epididymis, around the besides anatomical structures, and not only confined to the prostate in acute bacterial prostatitis. Then coming for the prostatic secretion culture, which is not done here, but it can be done here in the chronic one. Why? Because there are no symptoms, but we still want to find out what is the reason behind the inflammation. Therefore, we do the diagnostic prostatic secretion culture only in the chronic prostatitis. Now, coming to the duration of the treatment, it is 2 to 4 weeks. But it is 4 to 6 weeks, almost 1.5 month, 1 month in your chronic prostatitis. And sometimes it can go up to 12 weeks if the frequency of the episodes is recurrent. Like in a year, if the patient is coming to you maybe 4 to 5 times with prostatitis itself, then you can give the treatment a long duration of antibiotics for 12 weeks itself. Okay. Yes. Now, this is the drugs which are going to have penetration. These are the best drugs for penetration, and these are the moderate drugs for penetration. Now, best drugs for penetration into the prostates are what? These are the fluoroquinolones, ciprofloxacin, levofloxacin, then TMP, SMX, you have doxycycline, and you have macrolides. What are the name of the drugs in macrolides?
Azithromycin, erythromycin.
Okay, very good. So it is azithromycin or erythromycin. Now, aminoglycosides, what all drugs you have? You have vancomycin, gentamicin. These drugs are your aminoglycosides, but aminoglycosides have a moderate penetration. So, it is not recommended. First line drugs are always the ones which are having the best penetration, and that is your fluoroquinolones, TMP, doxycycline, and macrolides. The moderate ones are going to be aminoglycosides and your phosphomycin. Okay. All right. So was prostate clear for all of you? Yes. Is prostate clear for all of you?
Yes, ma'am.
Okay.
Yeah.
Okay. Any doubts anyone has?
Ma'am, in prostatitis, the investigation of choice will be DRE.
Yes. No, in chronic prostatitis, it can be DRE. But in acute prostatitis, you just have the clinical sign symptoms with you. You just do a WBC counts and urine culture, no other things. Okay?
Okay, ma'am. But
Yes.
in chronic DRE will be not positive, no, ma'am. Almost it will be normal, no, in chronic
It can
prostatitis.
be normal, or sometimes it can also show markedly raised inflammation at a mild level. But DRE generally we do in a chronic patient in clinical practice. But DRE prostate, sometimes you can do it in a acute stage also. Massage is contraindicated. But when, if you ask me as a real time question, we do not, what do you say? We do not ratherly just go ahead with DRE for the prostate. Why? Because the clinical signs symptoms of the patient are sufficient to analyze whether it is prostatitis or not, and then we immediately start with the treatment, and we do not wait for any other further diagnostic methods. But yes, in case of your exam, if they are asking you DRE prostate is more beneficial in acute or chronic, your answer has to be the acute one. Okay?
Okay, ma'am.
Yes. Any other doubts? Anyone? Okay. I guess it's clear enough. Fine. Did you understand the penetration, better penetration drugs and the moderate penetration drugs? So in case if in exam they are giving you options, okay, that there is going to be vancomycin, there is going to be your ciprofloxacin, and there is also your phosphomycin as and none. And there is going to be a 61-year-old male with chronic prostatitis. What will be the drug of choice? Tell.
Cipro or levo?
Yes, very good. Ciprofloxacin. And what will be the duration?
2 to 4 weeks.
4 weeks.
No, 4 to 6
No,
weeks.
that
2
is
to
for
4 weeks
acute.
is for acute. Now here it will be 4 to 6 weeks. Look at this here. 2 to 4 weeks is for your acute, and 4 to 6 weeks is going to be for your chronic. Okay?
All right, ma'am.
Right. So this is clear, I guess. Okay. Next question. A man comes to the emergency department with fever and a murmur. Blood cultures grow Clostridium septicum. Transthoracic echo shows a vegetation. What is the most appropriate next step in the management of this patient? Colonoscopy, your transesophageal echo, CT
Surgical
abdomen.
wall replacement.
Okay, surgical wall replacement, and repeat the blood cultures. Can you please tell me what is the surgical wall replacement? What is your direction of going ahead with this treatment? Please elaborate me, doctor.
I feel because until surgical wall replacement is done, like there is no other option in this case because the infection will spread through.
Okay. What are the other answers? Fine. Colonoscopy. Dr. Piyush Patel, Dr. Mifra, everyone saying colonoscopy. Yes, Dr. Mifra, why would you do colonoscopy?
Ma'am, Clostridium, the origin we have to exclude. So
Clostridium
colonoscopy, yeah,
septicum origin we have to exclude. So you think that we have to do colonoscopy, right?
yeah.
Okay. Yes, I'm getting
Septicum
other
is
answers.
highly associated with colonic diverticula.
Okay. Repeat the blood cultures also is one of the answers that I'm getting. Dr. Sudesh, Dr. Musman. Okay, Dr. Sudesh, can you just elaborate why would you say that repeating the blood cultures should be there? Why should we repeat the blood cultures?
Yes, madam. Can you hear me, madam?
Yes, I can hear you very
Yes.
well.
Yeah. Now the question says that the man comes with fever and murmur and blood culture growth, and patient.
Yes.
Yes. Patient shows vegetation.
Vegetation. Okay, so
Yeah.
vegetation is there on the wall. As one of the doctors have given us the input that surgical wall replacement can be one of the options. Okay, now next step in the management. See the question very well. What is the most appropriate next step in the management? Surgical wall replacement will be the end step or your definitive management. But when we are going ahead with the next step in the management, what should
Colonoscopy.
be? Yes,
Rule
the
out
answer
malignancy.
should be colonoscopy. As Dr. Mifra said that we have to track down where is this Clostridium septicum coming from. We have to see for the colonoscopy. Why? Because there is going to be a diverticuli to the polyps or there can be colonic cancer. Then this is the reason that we have to check where is this source of infection from. Okay, so therefore colonoscopy will be the next best management. Let me again explain you. See, he is a patient with fever and murmur. That means there is active infection focus first. Second, when the blood cultures are showing that there is a Clostridium positive, then what we have to do, a trans echo was done. The next management was also done very well. When the trans echo was done, it was showing vegetation on the walls. So vegetation on the walls, ideal treatment is first stabilize with the help of antibiotics and then go for a surgical wall replacement. Okay. Now here the question is next appropriate step in the management. Next appropriate step, just because there is a Clostridium, our step has to be colonoscopy. If this was not Clostridium, if this was something related to the Streptococcus pyogenes maybe, what would you be doing?
Treatment with antibiotics and replacement of the valve.
Yes, antibiotics. And we would sometimes do your HRCT for thorax. Okay, if it was somewhere related to the Streptococcus other group. HR for any respiratory infections. Okay, so now let us focus on this question. What is it here? There is no point in repeating blood cultures if it is already positive. Wall replacement is premature. Later on, we can do the wall replacement. Also, one of the right answers, but the exact specific answer is your colonoscopy. This organism is just not an infective endocarditis organism. It is classically associated with GI malignancy. Remember, GI malignancy, colonic cancer has to be your Clostridium. So, any patients coming to you with fever, murmur, and vegetation on the heart walls and shows Clostridium, always suspect a GI malignancy, especially the colonic cancer. Now, coming to the mechanisms, how does this Clostridium septicum thrives in? there is going to be the necrotic tissue destruction, there is tumor hypoxic environment, colonic tumors, mucosal breach, bacteremia, and they lead to the heart wall. So basically what is happening? Clostridium, as everyone knows, it is an anaerobic organism. This anaerobic organism is going to cause you necrosis of the tissues and then cause you colonic tumors, mucosal breach. The intestinal mucosal layers are going to be destructed slowly, and it is going to be a bacteremia in the body, then reaching out to the heart walls. So basically, this is how the Clostridium is going to get inside the body. Okay, so this is a perfect table for your all infective endocarditis organisms. What can be the possible hidden disease, and what is the pathophysiology, and what is the key pointer for your exam. Remember this table, you can take a screenshot maybe, this is important. When we talk about Streptococcus galeolyticus or Streptococcus bovis, which we commonly say that, this is also associated with colon carcinoma or colonic polyps, maybe adenomatous polyps, juvenile polyps. All this can have your Streptococcus bovis. How do they act? They act from translocation from the tumor mucosa. And bovis, always remember B for bovis, B for bowel tumor. Okay. Clostridium septicum, just like it was there in our case, there is colonic cancer, hematologic malignancy can be there, tumor hypoxic necrotic tissue growth. Because there is Clostridium, there has to be tissue necrosis. And remember, septicum, silent colon cancer. Enterococcus facialis, there is GI manipulation. GI manipulation or gastrourinary or gastrointestinal. Either of the system can get compromised if it is an Enterococcus facialis. Then there is going to be a normal gut flora, but the organism is going to enter into the blood. Just like the name itself suggests, Enterococcus, go ahead with endoscopy or your urological imaging. Okay. Ideally, a OGD scopy or a endoscopy, diagnostic endoscopy is recommended here. Staphylococcus aureus, what is going to be there? There is going to be skin infection, catheter-induced infection, indwelling catheter is there, direct bloodstream seeding is going to be there. And if it is Staphylococcus aureus, it is always has to be aggressive acute infective endocarditis. Which criteria do we use for diagnosing infective carditis?
Duke's criteria.
Blood
Duke's criteria.
culture, which is 3 separate blood cultures.
Okay,
when
it's
is
modified Duke's. Okay, very good. Then coming to the Staphylococcus epidermis, what is going to happen? It is going to affect your prosthetic walls and the devices. Maybe your there is some pacemaker which is there, that can be also affected. Your aortic wall replacement, that aortic wall can also be affected due to Staphylococcus epidermis. Most common organism to affect the replacement walls, that is your Staphylococcus epidermis. Then there is a biofilm formation. These days there's a lot of research going on biofilm formation. Biofilm can be formed over any of the devices that is inside the body, or maybe on the catheter entry. It can be a biofilm formation. Then what do we do here? We do equipment infection tracking. That is most probably your nosocomial infection, hospital acquired infection. All this has to come via your Staphylococcus epidermis, and remember with it, it is a biofilm formation. Then coming to the Hackett group. Hackett group, anyone tell me what is the full form of the Hackett group? What do you mean by Hackett?
The
These are
organisms,
all
ma'am.
bacteria. Yes, these are all bacteria that it is going to be there for Hackett. What is it?
Haemophilus, Acinetobacter.
Okay, so H for
Shigella,
H for it
Campylobacter.
is very good. So it is Haemophilus. Then A is your Acinetobacter or Actinobacillus.
Campylobacter.
Yes. Then C is for
Campylobacter.
Campylobacter or Cardiobacter, you can also call it as. Okay, so it is a Cardiobacterium. C. Cardiobacterium hominis is the full name, but Cardiobacterium you can call it as. E for Echinella. Okay? Yes, E for Echinella.
And Kingella.
Yeah. And K
Kingella.
for Kingella.
Kingella.
Okay. All right. So these are the most common organisms. They can cause you dental infections. Also, they can cause you oral infections, and then in return cause you infective endocarditis. So this is the Hackett group. Hackett group infections can also be there. Also, in at times in immunocompromised patients, just like HIV or maybe TB, this Candida infections can cause infective endocarditis, but not in a normal patient. If they are suggesting that the blood culture shows Candida growth, so is that patient normal or he's seropositive? He has to be seropositive because he is immunocompromised. Then here opportunistic seeding is there, fungus, foreign line or low immunity. Okay, is this table clear for all of you?
Yes.
Yes, ma'am.
Okay. Now, if we are talking about the organism in the blood culture, just like it is Streptococcus bovis or Streptococcus galeolyticus, the same name. What is malignancy associated? Colon adenocarcinoma. This is the confirmed malignancy associated. So this table is going to tell you the blood culture, what organism we see, and what malignancy is associated with that organism. This is a very high yield table. Keep it with you handy. Okay. And here what you do colonoscopy. Then you have Clostridium, again the same thing, linked to colon cancer or leukemia, just like we have seen there was a hemolytic involvement. Here you do colonoscopy plus the blood workup. If it is H. pylori, this is a very common question asked in exams, all type of screening exams basically. H. pylori associated with gastric cancer and malt lymphoma. Which type of lymphoma? It is malt lymphoma. The ideal thing to do here has to be your OGD scopy, endoscopy with a biopsy. With a small piece they are going to take up and check whether it is urease positive or not for your H. pylori. Then you have to have your Salmonella typhi. It is going to be associated with what? With your GB carcinoma, gallbladder carcinoma. What is the appearance of the gallbladder looks in a carcinoma? Have you heard about something called as porcelain gallbladder? So whenever they use this word porcelain gallbladder, that means the gallbladder is into the malignancy or the carcinomatous stage. Here you will have biliary imaging to be done. Then Epstein-Barr virus. Epstein-Barr virus will be a nasopharyngeal carcinoma or your lymphoma. The viral load and the imaging has to be done. If it is your HPV, everyone knows it is your cervical cancer, anal cancer, CA rectum, oropharyngeal cancer. So HPV basically 16 and 18. These are the most infectious strains of your HPV. And if it is HTLV1, it has to be your adult T cell leukemia. Here what you have to do, hematology reference, and in HPV, the screening program has to be done. The typical protocol for the pap smear, the grading, the SIN classification, everything needs to be done in your HPV if it is positive on blood culture. Clear? Is this table clear for all of you? Any doubts anyone has?
Yes, ma'am.
Yes, you can be interactive. You can ask me the doubts. Okay. So let's move ahead for the last question of today. The most common cause of acute diarrhea in children is about what? It is bacterial, viral, fungal,
Viral.
parasite.
Viral.
Okay. Okay. So Dr. Mahesh, can you just elaborate me what all viruses cause diarrhea?
Enterovirus.
Rotavirus.
Adenovirus.
The rotavirus most common.
Rotavirus.
Okay,
Rotavirus.
perfect. Everyone knows that what is it? So the answer is rotavirus, which is the most common cause of acute diarrhea in children. Okay. So let us see the most common cause. It has to be your rotavirus, also norovirus, adenovirus, and astrovirus. They can cause you diarrhea in children. The viruses account for majority of acute watery diarrhea. So what will be the treatment in such cases? What will you treat this patient with?
Fluid replacement is the first thing. They have to
Okay. So
Just
there has
to
to be fluid replacement, there has to be ORS, there has to be zinc. Only this thing, and it is a self-limiting, it is going to be fine. Okay. So can anyone tell me what is the vaccine that they use for rotavirus? Do they give vaccine for rotavirus?
Yes.
But why
Rotavaccine.
is it discontinued?
Here in
Because
my
of the
country,
side effects.
we still give it
Okay.
the virus vaccine.
Yes, in some countries they are still giving, but generally it is according to the WHO, they have discontinued the usage in some areas. Why? Anyone?
Into susception.
And
Maybe
compared to
better
what
sanitation and hand washing.
Okay, there's just one line. Some necrosis it causes.
Into susception.
Necrotizing fasciitis.
Yes,
Necrotizing
yes, it
fasciitis.
causes intussusception with bowel necrosis. Okay, so that is the reason that they have discontinued the use of rota vaccine. The rota shield or rota rix, it was there, it is not used, but some countries they still follow, but majority of them it causes you intussusception and bowel necrosis, ischemic bowel necrosis. So this is the reason it is discontinued. Okay. Now, if it is why or not the other things, okay, we don't need that. Just let us see the high yield table. If it is an age group, that is, if this is a child, a neonate from 0 to 1 month, what can be the most common causative organism? It can be your E. coli, that is your EPEC strain, Klebsiella, and it can cause you sometimes Guillain-Barre, diarrhea, and poor feeding, lethargy, sepsis. So all this will be clubbed together if it is a neonate till 0 to 1 month, and the drug of choice or the management here has to be ampicillin plus gentamicin and IV fluids. So all these things will be in the management for your neonates if it is for 1 month. If it is an infant from 1 month to 2 years, what will you do? Rotavirus will be the most common causative thing. Norovirus, adenovirus will be the other parts. Here the patient will be having watery diarrhea, mild fever, dehydration. As we said here, what will be the management? ORS, zinc and continue feeding, but no antibiotics to be given in your viral diarrhea. Keep this in mind. Only supplemental therapy. If it is your toddlers, that is between 2 to 5 years, what will be the most common part? Again, here in toddlers also viral is the most common. If it is bacterial, it has to be your salmonella or your campylobacter. There is going to be fever, diarrhea, abdominal pain, abdominal cramps. Their ORS is your first line. Zinc, okay, you can give sometimes, but azithromycin will be the main line of treatment if one drug of choice you have to give. If it is a school age children, here there will be norovirus or Shigella or ETEC will be the strain of your E. coli. Now this ETEC is very related commonly with your travel history. One minute. So ETEC is related with your travel history. Any traveler's diarrhea is associated always with ETEC. Keep this in mind. And the drug of choice will be your ceftriaxone or azithromycin. Generally, your ceftriaxone is sufficient for ETEC. If it is a milder ETEC, then you can only give ORS. All ages, giardia, if it is causative, then the stools will be foul and greasy. There will, if it is an entamoeba histolytica, what will be the thing? The stool has to be what? Yes.
parasitic
Cold and greasy.
In
amoebas.
entamoeba, there will be bleeding. Yes, there will be bleeding. And here you have to give a luminal agent, that is metronidazole or satranidazole. These are all luminal agents that you have
And
to give.
anti-amoeba the history will be long. Like
Yes.
incubation period will be long.
Very good. So the incubation period has to be more than 14 to 21 days in entamoeba histolytica, mainly transferred via the water route. Okay. So here you have to give a luminal agent. Metronidazole is also the drug of choice, as well as sometimes you can give albendazole, satranidazole, or other type of drugs. So this was all for today from my side. I hope you had an informative class. Any doubts anyone has, please?
Ma'am, how to continue these classes? It is being very useful.
Yes, as I told you last time, you can connect with Dr. Munjal sir. He'll be the best person to assist you with the what packages you need or what exam are you exactly looking in for. Okay?
Okay.
Yes.
Yes, ma'am.
Yes, sir. I
Just
have
make me
made
the
you the
host, I
host.
guess.
Yes. Okay. There is a question. Traveler's diarrhea means traveling to geographical parts or local travel. Different geographical parts. Geographical parts doesn't mean like you're growing from the beach to the mountains. No, it means you're changing a zone, like changing a geographical or a topographic pattern. Okay, so that is your traveler's diarrhea. If you're traveling for 100 or 200 kilometers from here and there, it's not going to be a traveler's diarrhea.
Can you make me
Okay.
the host, ma'am?
Yes, sir, I have already made you the host.
Oh, should I use the same slide or I'll share my one?
Yes, sir, you can share your own
No,
slide.
no.
I have already made you the host. Are you able to do that?
Thank you, ma'am.
Yes.
Thank
Yes.
you, everyone. Please study well.
Thank you
Yes.
very much. Excellent class.
Thank you. Thank you so much.
Hello, good afternoon.
Yes.
Good
Good
afternoon.
afternoon, doctor.
Ms. Dr. Anisha.
Okay.
Oh, Akanksha, sorry. Dr. Akanksha.
Yes, Dr. Akanksha here.
Yeah. I just wanted to ask about the presentation. Can we also have presentation after lesson? Like to have a quick view
Yes, I
as
Yes,
will.
well?
you.
Like
You're Dr.
PDF or
Shahrukh, right?
PPT. Yeah, Dr. Shara. Good morning.
Yeah,
Good afternoon, Dr. Munjal.
good afternoon. We'll share you. Don't worry.
Thank you.
Could you make me the host, ma'am?
Yes, sir, you are already the host. I'll try it again 1 minute.
No, it's all good, all good.
Yes,
Just
you are already
confirm
the host.
my screen
Yes.
is visible or not.
Yes, it is visible, sir.
Wonderful. Thank you very much, ma'am. I was in the class throughout. Excellent, very crystal clear. Now a lot of doubts has been cleared to me
Yes,
as
thank you
well
so
for
much, sir.
infectious disease. So it's a really wonderful class. And it's very
Yes, sir.
tough task to present after the super duper coach,
No,
but
no,
I
not
try
at
my
all,
level
sir. We
best.
get guidance from you, sir. Not at all.
So I do my level best to make the audience engage. Okay, fine. Thank you very much once again, everyone.
Yes. Thank you, sir.
So this is
Yes.
Dr. Munjal.
Thank
I'm like hemato-oncologist and bone marrow transplant fellow. So let's start with the first slide. I would be glad to answer any random questions, believe me. So don't keep it in your mind. Ask any random questions related with this. Gonna probably next 60 minutes or at least leukemia part would be absolutely crystal clear, believe me. So just concentrate, try to participate, interact with it. So first question in front of you, in CLL, chronic lymphoblastic leukemia, patient has 13 grams of hemoglobin, WBC count of 80,000 per cubic millimeter, lymphocyte is 90%, peripheral smear showed mature looking lymphocyte, platelets are 200,000, on examination no lymphadenopathy, no organomegaly. What is the stage of the disease? What is the stage of CLL? Is it stage 1,
Stage
stage
0.
0, or stage
Stage
3,
0.
stage 4? You can post
Stage
your
0.
comment here. Okay, fine. I'll go through all the comments and then we'll discuss. Please. Yes. So one answer is 0. So do you think that there is a something like stage 0 or it start with stage 1? I mean, we always think of stage 1, 2, 3, 4 in malignancy. So is there like any stage 0? Yes, please. Now we are almost close to, I mean, I can say 35 doctors in the class. Fine. So can anyone be a volunteer? Dr. Kavita, how did you get to know that this is stage 0 and how you define the stage 0, 1, 2, 3, 4? Any idea?
And there is lymphocytes, and there is no lymphadenopathy, no organomegaly, and the
Fair enough.
platelet is also normal. There is no thrombocytopenia. So
Fair enough.
I'll go with
So,
stage
so,
0.
so stage, right? So stage 0, how you classify stage 0? Is there any definition for stage 0 that, okay, fine, this is the things, this is stage 0, this is the thing, stage 1, 2, 3, 4. That is what we want to understand. So let me tell you, when the patient has only lymphocytosis or absolute lymphocyte count, can anyone tell me how much is the absolute lymphocyte count should be there? Can anyone count in this patient how
Not
much is
more
the
than
absolute lymphocyte
11,000.
count? Sorry?
Not more than 11,000. That is the upper
Oh,
limit. And this is 80,000.
okay. So how come so the staging is depends on the number of the count? So if you classify that CLL stage 0, how you classify? Is there any number which decide the stage 0, 1, 2, 3, or what exactly is in your mind? That is what I want to understand. Yes, anyone, it's open for all. Someone can classify how you classify stage 0, 1, 2, 3, 4.
It's not related to the count.
Okay, then it's related with what things? Then how you supposed to know that there's a stage 0, right? You answered well, you answered right, but I want to know how did you, right? Should be no mug up, no? We need to know that okay, this is stage 0, this is stage 1, this is stage 2, 3 and 4, right? So I will tell you. So absolute lymphocyte count. So I will teach you the trick. Absolute lymphocyte count. So it is total count multiplied by lymphocyte divided by 100. So total count here it is mentioned already 80,000, right? So 80,000, right? So we'll put it 80,000 here. 80,000 lymphocyte count is 90% divided by 100. So if you remove 20 from here and here, it is 72,000. 72,000 is a absolute lymphocyte count. Say for example here 90% is lymphocyte and 10% is neutrophil. 10% neutrophil. So what is absolute neutrophil count? Same formula, total count multiplied by neutrophil divided by 100. So total count is 80,000 multiplied by 10% is the neutrophil divided by 100. Right. So this is what the thing is. So this is 8,000. Same way you can do calculate five things, right? Absolute lymphocyte count, absolute neutrophil count, absolute eosinophil count, absolute basophil count, and absolute monocyte count. There is no rocket science. Total count to multiply by whatever you want to do divided by 100. So if you put here neutrophil, it is absolute neutrophil count. If you put here lymphocyte, absolute neutrophil. Eosinophil likewise. Are you getting me? Yes or no? At least please tell me yes or no.
Yes, sir.
Yes.
Yes.
Yes, sir. Yes, sir.
Wonderful. So
Yes.
this
Yes,
is so
sir.
far clear, right? What we are trying to understand here. So this is all clear. Wonderful. So now what they are asking here is, right? What they are asking here is the stage. So how we supposed to know the stage of the disease, right? So for the staging, let me add one more slide, right? So this patient is CLL patient, hemoglobin is fine, WBC is 80,000, lymphocyte is 80%, peripheral smear shows mature looking lymphocyte, platelet is 200,000, no lymphadenopathy and no ergonomegaly. That means, right, something is there, means it is like new things. So now let me guide you. So how we supposed to do the stage? So stage 0 is only one thing. There must be only absolute lymphocyte count more than 5,000. Absolute lymphocyte count is more than 5,000, right? It's stage 0. Only absolute lymphocyte count is more than 5,000, right? Second stage, this is stage 0. Stage 1 is what? Right? Lymphadenopathy. Stage 2 is stage 1 plus or minus hepatosplenomegaly. Stage 3 is anemia. And stage 4 is thrombocytopenia. Are you getting me? Yes or no? So when you are going for stage 4, there must be one thing amongst this. If you are going for stage 3, means you have anything from stage 0, 1, 2. If you are going for stage 2, means anything from stage 0 and 1. So it could be hepatosplenomegaly plus lymphocytosis. Lymphocytosis is absolutely there in all, right? Without that, there is no diagnosis. So lymphocytosis plus thrombocytopenia, anemia, hepatosplenomegaly, lymphadenopathy, and only just lymphocytosis. So only lymphocytosis stage 0. Lymphocytosis, right, plus lymphadenopathy 1. Lymphocytosis plus hepato or splenomegaly or both is 2. Lymphocytosis plus anemia, definition of anemia is less than 12.5 gram percent, right? With other causes of anemia is excluded, and thrombocytopenia likewise. So are you getting me what I'm trying to explain? Right? So in our context of this, right, in with this context, right? What is the answer? In CLL, hemoglobin is fine, so no anemia, right? We'll try to rule out. We'll try to rule out, right? So 13 gram is not anemia, isn't it? Right? So 13 gram is not anemia. So no anemia. Stage 3, anemia is stage 3, right? There is a mature looking lymphocyte, no thrombocytopenia, 200,000. So not a stage 4, right? No lymphadenopathy, not stage 1. No organomegaly means hepatosplenomegaly. So no stage 0, no stage 1, no stage 2, no stage 3, no stage 4. It is just the lymphocytosis. And we calculated absolute lymphocytosis 80,000 multiplied by 90 divided by 100 is 72,000, and our definition is more than just 5,000. That's it. So this is stage 0. Is there any doubt or any confusions, or still there is a lot of question in the mind how we supposed to do it? Yes, anyone? Any queries, any confusions, any questions? Anyone has any confusion?
No, sir.
Wonderful. Asking is a good thing. Don't shy. I've seen that a lot of people shy. So no question is irrelevant questions. All questions are valid questions. So whatever is going in your mind, let me tell you, you can ask anything randomly. You can ask. Don't worry, right? Don't hesitate to ask. Don't hesitate to ask, right?
Sir, are we
So
going
this
to
is what.
interfere
Yeah, please.
in stage 0, or are we just going to observe the patient?
Wonderful. I'm coming on that point, doctor. So this is the first thing, right? So what's our diagnosis is right here in our
CLL.
case. Yes. So our diagnosis is CLL, right? So our diagnosis is. Sorry, I'm just trying to get my pen. Great. So, any questions? Three things: diagnosis, investigation, and treatment. That is what my triad is. So, diagnosis already they had given you, right? So, you don't need to stress about diagnosis, CLL, right? Investigations, right? So, for CLL, this is the most important. This is one of the most commonest malignancy, hematological malignancy globally and in the Western world. One of the most common, usually seen in elderly people more than 65 years of age. They gone for some body checkup, and incidentally they detected to have 90% of lymphocytosis with the high count, and they found CLL. They are stage 0. They don't know. It's like a silent diabetes. There are thousands and millions of people globally, those who have diabetes or pre-diabetic, but they don't know I have a diabetes, right? Because they don't have any symptoms, they don't have anything, but still they are moving around with the diabetes or pre-diabetic. Likewise, so stage 0, right, usually asymptomatic. Stage 1 is asymptomatic. Stage 2 is usually asymptomatic, but beyond stage 2, especially 3 and 4, you need a treatment, right? So can anyone tell me what could be the treatment, or what treatment you would like to treat these patients? Yes, anyone? Can anyone tell me what is the treatment of all 5 stages? So if I can ask you, Dr. Abida, right? What is the treatment of stage 0? What would be your answer?
Observe.
This is leukemia, chronic lymphoblastic leukemia. So how you
And
supposed
no
to treat?
treatment in
Okay,
stage
so
0.
no
1
treatment.
and 2.
Fine, fair enough. So we'll see it very quickly now. So here the correct stage is stage 0 as per the Rai. Rai is the name of the gentleman, Mr. Rai, who has given this Indian fellow, right, who is like a big name in US for CLL and lymphomas. So he has given the classification. That is how it comes named Rai classification. Reason, right? Isolated lymphocytosis, 80,000 count, 90% neutrophil, hemoglobin platelet fine, no lymphadenopathy. So this is stage 0. How you
Excuse me, sir. We
mnemonic?
can't see.
Sorry.
We can't see your screen, sir.
Oh, really? So what is the mnemonic for this? So let me share the screen. I guess it's gone. Yeah. Is it okay now? Right. So what's the mnemonic for this? Is it okay now?
Yes, sir.
Can you see it? Yes or no?
Yes, sir.
Wonderful. So these are the small mnemonic for how you remember, right? Lymphocytosis only. Yes. Lymphocytosis plus lymphadenopathy plus organomegaly means hepatosplenomegaly. Hemoglobin of less than 11 and platelet of less than 100,000. Why we want to stage this? Because the prognosis may change. If somebody says like I have stage 0 CLL, and they ask me the questions being a hematologist, sir, how long I supposed to live with the blood cancer? The name itself is very traumatic. Stage 0, I will take without treatment, you will live at least 10 years without treatment, just surveillance. And same fellow with CLL, with stage 4 coming and asking me, then it could be probably 2 to 3 years. See the difference, see the difference. Stage 0 completely, absolutely changed. But now here, right, the median survival for stage 0 is 150 months, more than 10 years even, right? So this is how the beauty is. So we need to classify and stage each and every cancer in the body, whether it is hematological or solid organ, like breast cancer, what the stage we need to know. Leukemia, what stage? Lymphoma, what stage? Myeloma, what stage? Right, we're gonna discuss this all things. Lung cancer, what stage? Head and neck cancer, what stage? Why you want to know the stage? Let me ask you, tell you the thing. Stage is the biggest, this is the question in exam, which this is the biggest prognostic factor for overall survival. Biggest. Stage 0, right? So say for example, stage 1 breast cancer, right? With all treatment, they live more than 90%. People will live more than 5 years, more than 90%. And likewise, same stage 4, right? Probably less than 20% live 5 years. See the difference in the prognosis. See 90% versus 20%, drastically reduced. So stage is one of the biggest, right, parameter or one of the biggest factor in deciding the uh, overall survival of the patient. So we need to know the stage of the disease, each and every, not just CLL, CML, AML, ALL, or you name the cancer. Whenever the cancer word comes, stage comes. Are you getting me? Yes or no? Yes or no? Right, so this is the stage. Now the same questions you were asking me, this is the answer for this. So what, how we supposed to interact, sir, with the with the stage? So stage 0 is observation. As I told you, stage 1 is also observation, right, provided it is asymptomatic. Even with stage 2, right, observation, right, if the patient is asymptomatic, if patient has symptoms or something wrong, right, treat effective otherwise. So bottom line is that in general, 0, 1 and 2, usually no treatment, especially no symptoms. No symptoms, no treatment. Here, even without having a symptoms, even if there is a no symptoms, you treat them. And it is rarely happen that stage 3 and 4, they does not have any symptoms. They may have some B symptoms, fever, night sweat, weight loss, bulky lymphadenopathy, hepatosplenomegaly, symptomatic anemia, symptomatic thrombocytopenia, gum bleeding, excessive menstruation, blah, blah. There are a lot of things to discuss. But they're supposed to treat this patient. Second, stage 3 and 4 supposed to treat this patient, right? So whenever patient comes to you with a CLL in stage 1, don't get panic. What is the biggest mistake? Is not the patient. Biggest mistake is the doctor. They get panic before. When we see the acute MI patient, patient is cool and calm, we get panic. Oh my god, acute MI, something goes wrong. Get relax yourself. Get relaxed. Don't get panicky. First, we have to be very cool and calm before treating the patient. So don't get panic with any cancer word, or try to evaluate what is the diagnosis, what is the stage, how is the prognosis, whether he require treatment or not. Right? Many a times they don't need treatment. Right? So this is the things. Right? So don't treat each and every malignancy. Right? Don't treat each and every stage of the CLL, especially their 0, 1, 2, right? And here they need a treatment. So what are the treatment options? There is a one drug, simple drug called as a chlorambucil. Chlorambucil was earlier drug, but newer drug comes, right? You can use, this is all in a fragile patient, right? Elderly patient, because these patients are more than usually 65 plus, male, female, present with the CLL. Very rarely in last 20 years I seen below 45, 50 years. So it's a disease of elderly age. Chlorambucil, right? And then CVP, cyclophosphamide, vincristine, prednisolone, right? RCVP, rituximab, bendamustine plus rituximab, FCR, fludarabine, cyclophosphamide, rituximab. I'm hemato-oncologist. I know each drug. You don't need to remember, but just for your knowledge, I'm trying to explain you. If something comes up the way, right, you should know that okay, fine. These are the drug. I heard of it. I know, I remember it. That's it, right? So you don't need to write. You are not going to write the hematology exam, but just for your knowledge, you must know it. That okay, fine. What's going on, right? So that is why I'll mention it here. All drug, right? So this is what the thing is. But bottom line is that you should know at least where to treat, where not to treat. So what is the bottom line? Observe if asymptomatic, treat if active disease, right? An indication to start the treatment, that we also know. So anything more than stage 2 need treatment. So right. So B symptoms need treatment. I told you what is B symptoms. B symptoms means fever, night sweat, weight loss. So this is tried wherever it also comes in lymphoma, non-Hodgkin's lymphoma. B symptoms, non-B, no B symptoms. So if somebody has a fever, or somebody has a night sweat, or somebody has a weight loss of more than 5% of baseline weight, it is called as the presence of B symptoms. If no fever, no night sweat, no weight loss, means no B symptoms. Why it is important here, right? Why they did not included headache, why they did not included back pain, why they did not included chest pain? This B symptoms carries the prognostic importance. Presence of B symptoms is bad prognostic factor. Fix in your head. So if somebody has a fever, night sweat, weight loss, right, and CLL is a bad than those who do not have night sweat, fever, weight loss. Are you getting me? Yes or no? At least tell me yes or no. Progressive lymphadenopathy, hepatosplenomegaly, organomegaly, right? And the lymphocyte doubling, fast symptomatic patients, bulky disease, all this condition require treatment. So these are the indications. So if you do not have B symptoms, no lymphadenopathy, no anemia, no thrombocytopenia, leave them alone. Just do surveillance. I have hundreds of patients so far in my practice. A lot of patients coming, I'm calling them 3 monthly, 6 monthly. Why? They are fine. No, they are in stage 0 for 1 year, 2 year, 3 year, 5 years. So I'm just doing the surveillance, monitoring. No treatment required. For kind knowledge, for your kind knowledge, starting early treatment, say for example in stage 0 and 1, you started treatment desperately, right? And one patient where you, right, so you have 100 patients in stage 0 1, I have 100 patient in stage 0 and 1, right? So you have 100 patient, I have 100 patient. You treated very aggressively or with some treatment, they live 10 years. If I don't treat them, they live maybe more than 10 years. Why? Because there is no complication or toxicity of the drug or myelosuppression, right? So starting early treatment in CLL especially does not improve the overall survival or lifespan of the patient. Are you getting me? Yes or no?
Yes, sir.
Wonderful,
Yes.
brilliant, wonderful, right? So that's it. That is the conclusion of all these things. So I'm not going much in detail. I have many things to tell you for CLL, but it would be only one lecture for CLL then. So I will jump on the next questions.
I have doubt.
Anybody has any questions? Yes, please.
Yes, sir. So the patient presenting with the CLL, he is having lymphocytosis and thrombocytopenia only. Can it be a possibility, and what will be the stage?
Stage is 4. Stage is 4, na?
Zero
Just
positive
remember
and
the 0, 1, 2, 3, 4. That's it.
um,
So 4 is thrombocytopenia. As let me go back to the this staging slide, so you just
even though
get
if
better
he
understanding.
doesn't have anemia or hepatosplenomegaly,
That's
we will
fine.
go
That's
with
fine.
one of
That's fine. That's
the
fine. This is the
sir.
international classification. What do you mean by anemia and thrombocytopenia? Means bone marrow is markedly involved by the cells, right? So normal hematopoiesis not happen, right? And that is why you are reduced erythropoiesis, reduced hemoglobin, reduced thrombopoiesis, thrombocytopenia, right? So it is almost not likely that patient does not have any symptoms, right, in stage 3 and 4, right? And even though they have minimal symptoms, treat it, because this is the end stage now. Patient may crash soon in 6 12 months. So before they get bad anemia, before they get bad bleeding because of thrombocytopenia, better to treat them.
Clear, sir.
Wonderful. Any questions to anyone? Otherwise, I'll switch to the next question. Fine. Not asking, I'll switch it. This question is one of the most important, very easy, and clarify hundreds of concepts here in this one slide only. 66 years old man comes to the physician for a 1 month history of fatigue. He has hypertension, hyperlipidemia, transient ischemic attack 3 years ago. He drinks 3 beer a day and sometimes a couple of more on social occasion. He currently takes aspirin, simvastatin, hydrochlorothiazide, metoprolol. His temperature is 37.1, pulse is 78, respiratory rate is 19, SpO2 is 97% and room air. He is not apparently in any distress. Physical examination shows conjunctival pallor, multiple pinpoint red non-blanching spots on his extremities. On abdominal examination, spleen is enlarged. Laboratory study shows hemoglobin concentration of 8, leukocytosis count is 80,000, platelet count of 34,000. Peripheral smear shows immature cell with a large prominent nucleoli and elongated needle-shaped cytoplasmic inclusion. Which of the following is most likely diagnosis? So take your own time, right? Take your own time. I need to answer. There is in this slide there are 100 questions. 100. Believe me, I'll count you 1 to 100. Here they are asking the diagnosis. So first diagnosis, then how you supposed to investigate, how supposed to treat. Yes. Who wants to comment? Yeah, we have many doctors, 35 plus doctors, and answer is only 3. I'm not happy, honestly speaking. So post more answer. Post more answer. We have just 2 or 3 answers. Yes, Dr. Piyush Patel, sir. Would you like to comment on this? Anything? Yes.
These are, these are air rods, needle-shaped cytoplasmic insulin. I guess is option A.
Okay, fine. So let's you and me will discuss 100 MCQs now. Right. So AML. Right. Now I'll do the dissection of the whole questions. Right. Dissection. It's fine. I mean, if we do 2 MCQ less, but if you listen me lifelong, you remember all leukemias, even complicated. Right? So now they have in history, right? They have low hemoglobin. Because of low hemoglobin, he has a fatigue. He has a high count, maybe risk of infection. They are not working well. Platelet counts are low. Platelet counts are low, and that is why they have, because of low hemoglobin, there is a fatigue and pallor. Pallor. So matching. Low hemoglobin, symptoms is fatigue, sign is pallor. Low platelet count, right? Bleeding. So this is all bleeding. Multiple pinpoint non-blanching spots on the extremities, usually seen on extremities. So bleeding, right? His spleen is enlarged. Spleen is enlarged. So splenomegaly. So splenomegaly, right? It can be seen in AML as well. Peripheral smear. So what is peripheral smear? When you take a CBC, you make a slide like a tongue-shaped slide you make. This is called peripheral smear review, right? So in peripheral smear review, you see all the red blood, white cell, and platelet counts and everything. All you see under microscope is peripheral. Normochromic, normocytic, cystocyte, schizond, malarial parasite, right? Hypochromia, sickle cell, right? Target cell, right? Teardrop cell, everything is in the peripheral smear, right? So this peripheral smear shows immature cell. So immature cell usually not seen in a normal person. Immature cells usually in the leukemia, for your knowledge. Because if somebody does my peripheral smear, Dr. Munjal's peripheral smear, there should be no immature cell. There is all mature cell, right? There is no immature. Immature cells are usually in the bone marrow. So when immature cells are come from bone marrow to blood, until proved otherwise, it's leukemia with large prominent nucleoli and elongated needle-shaped cytoplasmic. So I'll draw the description of this. This is a cell. This is nucleus, nucleolus, right? And there is the elongated, I'll do the dissection, needle shaped cytoplasmic. This is needle, kind of needles. Why this is cytoplasm? It is situated in the cytoplasm, not in the nucleus. So elongated, pin-shaped cytoplasmic inclusion. It is none other than or
Or
rods.
red.
Or rods. Or rods fix in your head. Or rods is equal to AML. Three possibility go on. No CML, no CLL, no ALL. Fix in your head. Or rod is equal to AML. Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Yes or
Yes.
no? Wonderful, brilliant. So now this looks
Yes, sir.
easy now. Question is easy now. Wonderful, brilliant, right? So this is, I mean, without doing anything, it is AML, right? We excluded it already. Why? Only one thing. If you don't need anything, if you don't read all 10 lines, but if you know this is needle shaped cytoplasmic, it is AML. Whatever the story they had given here, don't worry. Whatever the story there, or rod is equal to AML. AML is equal to or rod. Is that clear? Right? So by giving the long scenario, they're trying to confuse you, but don't confuse yourself. We are going conceptualized. That is why we are not confused. I'm not confused at all. You give me any CBC, 10 CBC without anything HB total count platelet, I'll tell you, okay, fine, this is the diagnosis. That we'll see it in some slides. So key finding in this term, 66 years favors AML, right? So why not ALL again, right? Now our job is not just to get the answer, our job is to, right, our job is to get the why this is not, right? So 66 years of age, ALL not happen. ALL usually disease of children, less than 10 years are the most commonest presentation. Fatigue pallor is bone marrow failure. Splenomegaly, CBC is showing anemia, leukocytosis, thrombocytopenia, immature cell, large nuclei, prominent nuclei, needle shaped inclusion, right? So this is OR rod. These are the OR rod, and OR rod is equal to myeloid, no lymphoid, never seen in ALL. That confirms the AML, right? Let's jump to the head-to-head comparison, AML and ALL, right? For this patient, right? So how we supposed to diagnose, right? Typical age, ALL, children. This is our is 66 years. So matching this, or rod usually absent in ALL. It is absent. It is present in our case. Needle shaped cytoplasmic inclusion. It is or rod. Cytoplasm scant and no rods. It is needle shaped. We have it. And common markers TDT and CD100 is a marker of lymphoid. So it is present in lymphoid leukemia, which is not present. What is present here in AML? AML. What is present? AML. M means myeloperoxidase positive, Sudan black positive, TDT negative. What is positive in ALL? It is negative here. Here TDT positive. So this is another question. If you count one question, it is 100 question. So myeloperoxidase positive in which leukemia? AML, ALL, CML, CL, AML. This is AML. This is ALL. This is ALL. No CD20 in AML. That's it. So this is basic, right? Let's move my clock forward, right? So why not CLL? Mature cells are seen. In our scenario, what they are saying, immature cell. Very clear cut. So we are not confused. Immature cells are not seen here. All mature cells, small cell, indolent course. Indolent course means usually are they are in stage 0, 1, 2. As I told you, so indolent means no symptoms, slow growth, right? So they are almost asymptomatic, right? So here the acute presentation, no slow growth, blast cells, cytopenia, rule out CLL. Why not CML? CML, all stages of maturation. What do you mean by all stages of maturation? So I'll show you. So this is a stem cell. Stem cell cause myeloblast. Myeloblast cause promyelocyte. Promyelocyte. Promyelocyte to myelocyte. Promyelocyte, myelocyte, metamyelocyte, band cell, and then neutrophil. This is the evolution. I'm just trying to, you don't, if you don't remember this cycle, fine, fair enough. I'm just trying to tell you to make you to build your concept, right? So what is seen in your and my blood is this all is not seen. Let me tell you, this all not seen. What's seen in your blood and my blood is neutrophil. We don't see the band cell. Go and check it out tomorrow, the CBC of any random patient. Can you see the band cell? If the band cell is seen, it is not good thing. Either it's infections, inflammations, bone marrow stress, or it's a leukemia, or B12, or CML, chronic myeloid leukemia. So this all will not see. This is all a product of bone marrow. This is product of blood. So what we see, and this blood is mature. This is called mature. This is all bone marrow is immature. They are still not mature. That is why they are in marrow. Once they become mature, they come to the blood, right? So here the mature cells are seen. CLL mature, right? In our scenario, immature cells. So immature is not seen, right, in CLL, and all stages of myeloid maturation. So in CML, right, you can see because of excessive count, what they are saying, all stages of myeloid maturation. So we start with the myeloblast or myeloid. So these all are the myeloid, right? So these all are seen in CML, right? So all stages of myeloid maturation. See, basophilia is absolutely prominent, right? But but often they have very high WBC count and no blast or rods in the peripheral. No or rods typically seen in CML. It is only in AML, and that is why it is not a CML, right? So this is what the cascade is. I'm gonna teach you very shortly. Is that clear to everyone? Yes or no? Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful,
Yes.
brilliant. So final diagnosis is AML. How come any leukemia with or rod is a AML? You don't need to apply any brain. AML is commonly in elderly. AML can cause anemia, thrombocytopenia, leukocytosis common, and or rod is AML, and common is seen in AML M3, right? And they usually present with DIC. We'll see it in one next slide. Now, if you want to go more bit in detail of this slide will conclude all four leukemias under one roof, right? So if you listen me more carefully for next 5 minutes for this MCQ, your leukemia is clear. AML means acute myeloid leukemia. So let me tell you the leukemia, how you supposed to classify leukemia by two ways, right? By two ways. One is by speed. How is the speed? How fast they develop. Then it is acute and chronic. This is one classification, simpler. And what cell lineage involved? What cell lineage? Myeloid or lymphoid? Right? Now you have four combination. Acute myeloid, chronic myeloid, acute lymphoid, chronic lymphoid. So there are four entity. Are you getting me? Yes or no? I'm trying to make it very easy for you guys. Are you getting me? Yes or no? Right? So acute means fast, myeloid means myeloid series involved, and leukemia is leukemia, obviously, right? Same way, acute fast, lymphoid means lymphoid line is involved, lymphoblast involved, and leukemia. This is chronic. So acute has two, right? As I told you, by speed, acute and chronic. So by speed, two, acute and chronic, right? And by the lines involved, myeloid or lymphoid. So M means myeloid, L means lymphoid, M means myeloid, L means lymphoid. So either how you classify globally, right? How fast they develop and what cell lines involved. Are you getting me? Yes or no?
Yes, sir.
Yes. Wonderful. Right. So that's it.
Sorry, sir, I
Yes.
missed this part. Uh, can you say that again?
I'll I'll tell you. Don't worry. Yes. So leukemia, basically leukemia, right? When we talk about leukemia, it is classified in two ways. One second. Sorry. Okay. So when we talk about leukemia, right? So broad classification is leukemia, right? By speed and by cell line involved. If they develop fast, it is acute leukemia. If they grow slow, it is chronic leukemia. If they involve myeloid cell, it is myeloid leukemia. If it is lymphoid cells involved or lymphoid involved, is lymphoid leukemia. So now how is the combination? Acute myeloid. So acute myeloid leukemia, acute lymphoid leukemia, chronic myeloid, chronic myeloid leukemia, and chronic lymphoid leukemia. Are you getting me? Yes or no?
Yes, sir. Absolutely.
Wonderful, brilliant. So this is the basic thing. You don't need to mug up, right? So where we started is like it is acute leukemia, AML, ALL, CML, CML. So onset itself, acute means acute, fast, chronic means chronic. So AML usually adult and elderly. I have very, I mean, I'm seeing quite lot leukemias in my practice, but we see very small number of pediatric patients, typical age, right? So pediatric patients category is less, right? Highest pediatric category is in, I can say, in the pediatric category where we see in ALL, acute lymphoblastic leukemia, right? So this is the most important is ALL. So any child present to you with abnormal CBC, first differential diagnosis is ALL. Why? ALL, acute lymphoblastic, usually not seen in myeloid. AML usually not seen in children. CML is usually middle age, not the pediatric age group or children. And this is, I told you already, the long history, more than 65 elderly people, right? So even age can give you the tremendous idea, right? If somebody says, sir, my patient has a pancytopenia and age is 5 years, without thinking second thought, first rule out ALL. That's it. It is more commonly in children. Are you getting me? Here, the myeloid leukemia, myeloblast, lymphoid leukemia, lymphoblast, myeloid leukemia, myeloid things, lymphoid leukemia, lymphoid things. But what is the difference here and here? This is all immature, acute. This is all mature. Chronic is mature. This is mature B lymphocyte. Here the mature myeloid series. Peripheral smear, myeloblast. Here the lymphoblast. All stages of maturation, and here the mainly small mature lymphocyte or rods present only here. Can you see clear cut? Not here, not here, not here. So whenever you are asking the AML questions, go back retrospectively in the exam and look at, are they mentions about the or rod? Yes, you are done. Whatever they are confusing you, don't confuse or rod. If you see description or picture, AML. Nucleoli, it's prominent here, here usually absent here. Platelet counts, usually in acute leukemia, the most striking feature is thrombocytopenia. In acute leukemia, the most striking feature is a thrombocytopenia, right? In acute leukemia, right? Which is not the case in chronic leukemia, which is not the case in chronic leukemia. So chronic leukemia, usually they have a, usually in chronic leukemia, they usually have normal platelet count. So any patients comes to you with the thrombocytopenia and abnormal CBC like hemoglobin 9, WBC of 40,000 and platelet count are 60,000. Platelet count low in abnormal CBC until proved otherwise. Acute leukemia could be myeloid or lymphoid. That we'll discuss. Triage, right? Anemia is common, right? Like this thrombocytopenia common, anemia is also common. Here usually normal, right? And splenomegaly is massive. Amongst all four, CML is the massive splenomegaly, right? So this is a, right? So massive. This is a lung. The spleen is like small, right? Small. Spleen is very small, right? But it becomes, this is umbilicus. So spleen is just left upper quadrant or right, left upper quadrant of the abdomen. But instead of this, this becomes so huge, even it goes up to the right iliac fossa, right? So it could be more than 12 centimeter, right? It could be 18. I have seen complete whole abdomen is covered with this spleen. Massive splenomegaly. Causes of massive splenomegaly, one of them is CML, chronic myeloid leukemia, right? So this is very, very important. This all points, tips and tricks that will help you, right? Splenomegaly, massive in CML, lymphadenopathy is common in lymphoid. Lymphadenopathy is a lymphatic organ, not the myeloid organ. So lymphadenopathy is not in myeloid. That is why rare in AML and CML, more common in lymphoid. Acute lymphoid means lymphadenopathy. Chronic lymphoid means lymphadenopathy. So lymphatic is more common in lymphadenopathy is more common in a lymphoid leukemia, either ALL or CLL. Or rod is only present in AML. This all you don't need to remember. AML, you can't see the Philadelphia chromosome, that is 922. We have MCQ, we'll discuss. ALL usually accept, but there are precursor B ALL where you have uh, PH positive or Philadelphia chromosome positive or translocation of 922 positive, but it is commonly present in CML. 95% of the patients, those who present with CML, they have high count, they have neutrophilic leukocytosis, massive splenomegaly, and presence of Philadelphia chromosome or oncogene is 922 BCR able positive. Treatment of choice is imatinib, dasatinib, nilotinib, and bosutinib. That's it. That is a TKI. We'll cover sometime for your kind knowledge. Leukocyte count usually high or low, usually high or low in leukemia, acute leukemia, but it is absolutely high in chronic leukemia. All are mature, right? So thrombocytopenia in CLL is stage 4. Usually the counts is high. The counts is high. Here high, it can be low because many acute leukemia I'll see is like present with pancytopenia, low HB, low WBC, low platelet. That is why it is low. It can present with 50,000 count, 100,000 count, but the commonest presentation is pancytopenia, and those patients have pancytopenia have better prognosis than high count. For your knowledge, prognostically, treatment is all required except CLLC, often observation. Are you getting me? Yes or no? Treatment often stage 0, stage 1, stage 2, often observation. Stage 3 is anemia, stage 4 thrombocytopenia. So in that, but most of the patient they present right incidentally detected, so they don't need treatment immediately, right? But in acute leukemia, answer is yes, you need the treatment earliest. Once you establish the diagnosis, you need a treatment. It is targeted therapy. What do you mean by targeted therapy? So, tyrosine kinase inhibitor, the drug imatinib, which blocks the oncogene. The name of that oncogene is BCR-ABL, BCR-ABL. Right? This gene is responsible for uncontrolled overgrowth of white blood cell, and that is the pathophysiology of CML. So, if you block this oncogene by giving the drug imatinib, the WBC cell growth will reduced, splenomegaly reduced, eosinophilia reduced. So within 3 months of time, they becomes normal. And this is a wonder drug, and this really open up the doors for many targeted therapy globally. And for your kind knowledge, being hemato-oncologist, targeted therapy is one of the most fastest evolving field in the medical oncology and hematology, along with the immunotherapies, right? So targeted therapies, many targeted therapies are used. I'll give you some example just quickly for your knowledge because it is related with the exam, right? So which, right? So in CML, the targeted therapy is imatinib. So three things. CML is disease, chronic myeloid leukemia, targeted therapy name is imatinib. In breast cancer, estrogen receptor positive or progesterone receptor positive will give tamoxifen or letrozole. Targeted therapy will give, right, in non-Hodgkin's lymphoma, we give rituximab. Rituximab is anti-CD20 antibody, right? So it targets the anti-CD and CD20 on the lymphocyte, and it kills the cancerous non-Hodgkin's lymphoma cell. Targeted therapy. We use the herceptin or trastuzumab for breast cancer who have HER2 new positive, human epithelial receptor type 2 positive on the. So this is a breast cancer cell, ER positive, PR positive, HER2 positive. So if ER positive or PR positive, right? If you block this receptor by giving the tamoxifen, it will stop the growth of the cancer cell. It will stop the growth of the cancer cell. And if you have HER2 positive and if you block HER2 by trastuzumab injection, it will also stop the growth of the cancer cell. So we need to do ER, PR, and HER2 for each and every patient of breast cancer globally because it adds two treatment. One hormonal treatment, one is targeted. Both are targeted. They're targeting hormone, they're targeting specific receptor on the breast cancer cell. So this is few example. There are hundreds of example of targeted therapy, but just make you clear what the targeted therapy is all about. So targeted therapy is the drug of choice for many cancers nowadays. So always give a hope to your patient. Don't tell them, oh, nothing has been done now. You are stage 4. You are gone. You will live 6 months. There is no hope. Believe me, there is a thousands of treatments now available. I can advise to my patients, don't lose of hope. Stage 4, don't worry. I have a treatment for you. So don't lose the hope. right? So that is why it's important. That is why I discussed 5 minutes more for targeted, though probably it's
For
not your
non-Hodgkin's
area of interest.
lymphoma,
Sorry, ma'am.
sorry to interrupt. For non-Hodgkin's lymphoma, what did you say? It was the
Rituximab.
targeted
The
therapy,
name of
rituximab.
the injection is rituximab, and what it target is anti-CD20. Is that clear?
Yes.
Wonderful, brilliant. Hopefully you are enjoying with me. Fine. So what is the key example? AML or what is AML, right? ALL most commonly in children, TDT positive, CNL and testicular involvement is common, CML massive splenomegaly, Philadelphia, treatment is imatinib. That's it. We discussed everything all, right? So I'm not going much in the prognostic things, right? This is how you looks under microscope. How you know, sir, you told me myeloblast, lymphoblast. What's the difference? So myeloblast is like a larger cell, which you can see under the microscope. It is a larger cell than this. So this is size is larger. Cytoplasm is moderate, scanty is very, very less. So what is cytoplasm? This the free space is the cytoplasm. Rest of all is nuclear. Here you can see a big cytoplasm. Means the means the space between the cell membrane and the nucleus is large. Here you can see only thin, very, very small. Whole cell is occupied by with the nucleus, right? So here the cytoplasm is moderate or good. Here scanty or very less. Or rod is present. So this is or rod. This is or rod. This is or rod. Brilliant, beautiful. It is present. It is always absent. Nuclear chromatin is fine. Here course. What is fine? Nuclear chromatin is fine. Here course like dot 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 course. Nuclei prominent. 1 to 4. 1 to 4. 1, 2, 3, 4. Kind of things. Here indistinct. There are a lot of thousands of dot like things, right? You can't count. So indistinct. It's not distinct. So this is what the thing is. And myeloblast and lymphoblast develop from the hematopoietic stem cell, and hematopoietic stem cell from developed from pluripotent stem cell, and this developed from the totipotent. So this is all the genetic or cytogenetic. So this is the number one cell, right? Totipotent will give you the pluripotent, and then hematopoietic stem cell, and from hematopoietic stem cell, right? Hematopoietic stem cell will give rise to hematological tissue. Mesenchymal stem cell will give you the mixed connective tissue, bone, muscle, ligament, cartilage, mesenteric, right? Cardiac stem cell will give you the tissue of cardiac muscles and cardiac system, right? So these are the various different type of stem cell therapies. Not going much in detail, but just for kind knowledge, hematopoietic stem cell you must remember, which will give rise to two cells. This is all immature cell, not seen in the blood. It is seen only in the bone marrow. So this is wherever blast means immature, right? So this is seen in the bone marrow. If they seen myeloblast seen in the blood, it is leukemia. Lymphoblast seen in the blood, leukemia. That's it, as simple as that. You don't need to mug up. So in the blood, all mature cells, no immature cells. When there's immature cells, something goes wrong, right? So this is all I already told you. This is again exam question, so I want to spend more 30 seconds on this. So which enzymes cytochemistry, right? So cytochemistry, cyto means cell and chemistry means the chemical study of the cell. So this is a cell. You don't know whether it is a myeloblast or lymphoblast or it's a undifferentiated. How you supposed to do? You do a test on this. You do the name of the test MPO, chemical test, right? If it is positive, myeloid. If it is negative, lymphoid. If it is positive, myeloid, negative lymphoid. Sudan Black, positive myeloid cell, lymphoid cell. Pass and TDT negative here, opposite positive here. That's it. So this is exam question. They give you a long scenario and they say the cytochemistry of the cell is showing TDT positive. What is your diagnosis? ALL, lymphoblastic leukemia. Long scenario, they say myeloperoxidase is positive, AML, not the ALL. Are you getting me? Yes or no?
Yes, sir.
Wonderful, brilliant. It looks little complex subject, but it's important. It took me to reach here 20 years and I'm trying to give in 1 hour. So little difficult, but anyway, I try my level best. Right, so this is bottom line, one line example. OR-ROD is equal to myeloblast is equal to AML, TDT positive, lymphoblast ALL, MPO positive myeloid. This is lymphoid. That's it. Right, and this is what the exactly the tree I had shown you already. Right, so this is very brilliant and beautiful picture here of these things. Right, so this is hematopoietic stem cell. Right, so this is a primary cell from where the blood generates. So one is myeloid. Right, so one series is myeloid series, or you can say myeloblast or myeloid series. This is lymphoid series. Myeloid series will give rise to myeloblast. Lymphoid series will give to lymphoblast. And only lymphoid, only two things will develop: lymphocyte, lymphoblast, lymphocyte. Right? There are lymphocyte, two type of lymphocyte: T lymphocyte, B lymphocyte. That's it. Rest of the all is done from the myeloid. So what myeloblast will do? It develops the erythrocyte, means RBC and hemoglobin. It develops the thrombocyte and platelet, and it develops all four cells differential. Most common is neutrophil. Second most common is right is this, but it is not developed by this. So neutrophil, eosinophil, basophil, and monocyte. This four developed by the myeloid series, and this developed by the lymphoid series. So in myeloid leukemia, right? So myeloid series is quite longer, too much of cells, right? So if something goes wrong with the neutrophil or eosinophil or monocyte or basophil or thrombocyte or platelet, is all myeloid leukemia or problem in the myeloid series. Only B and T lymphocyte has something abnormality. It is so it is a if there is a problem in the this mature B cell, that they develop CLL. They develop CLL over uncontrolled production of B cell, right? 10,000, 20,000, 30,000 CLL mature this, right? So this is again very important. Let me draw the picture to you for the more clarity. So this is the only thing is in the blood. My box is in the blood. Box number second is in the blood. Box number one is in the bone marrow. One is in the bone marrow. Second is in the blood. So you can't see hematopoietic cell in the blood. You can't see myeloid precursor in the. You can't see the myeloblast. You can't see the lymphoblast. If you see it, acute leukemia. If you see it, acute myeloid leukemia or chronic myeloid. I mean, we'll figure out. Are you getting me? Yes or no? Are you getting me? Yes or no?
Yes, sir.
And this is the cell. This is the red blood cell. This is the central pillar. This is like this some thrombocytes. If you see the peripheral smear, this is white blood cell, right? This is like myeloid. There are scanty of good cytoplasm, and there are OR rods. Can you see OR rods? Yes or no? Yes or
Yes, sir.
no? Very clear. This is what picture they will give you. This is not a clear cell. These all are rod. So this is a cell, right? And this is one. This is called OR rod. For your knowledge, OR rod. What if it is a plentiful of OR rod? This is called as a faggot. Faggots. Are you getting me? Yes or no? So faggots is multiple OR rod. Single is OR rod. So you have OR rods, AML. You have faggots, AML. I have no confusion. Do you have any confusion? And this is more commonly seen in acute promyelocytic leukemia, AML M3, and they usually present with the disseminated intravascular coagulation in our clinical practice. So DIC is one of the most commonest presentation of M3 subtype of AML. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. So this is again the slide for this. So I told you everything: stem cell, lymphocyte, myelocyte. That's it. So we already did it, right? Fine. So that's it. Let me have one last questions for today. Then we'll continue the hematology to the next sessions as well with the same slide continuation. So DIC, disseminated intravascular coagulation, is seen in which of the following AML? M3, M4, M2, M5. Number one, answer for this, and then there are 6 questions. Best prognosis amongst all AML, which subtype? Commonest AML, which subtype? DIC common in with which AML subtype and why? How to categorize AML by risk factor? How to treat high risk AML? What is ATRA and when it is and where it is used in AML? More 10 questions, but I'm just trying to cut short. Yes, please. So let me give you the answer for this. Listen it, fine, no problem, right? So this is the FAB classification, French, American, British FAB classification. So first, what you need to do clinically, how we supposed to. So when we see the abnormal CBC, tomorrow morning I'll see in my OPD abnormal CBC. I think of leukemia by CBC and peripheral smear. I'll think of leukemia, right? I'll see there is a more than 20% of the blast cell with or rods. I'll diagnose AML. Then AML, there are 7 subtypes, rather 8 subtypes. What are the 8 subtypes? So these are the 8 subtypes. M0 to M7 is total 8. 8 subtypes. You don't need to mug up, but important to remember, right? They ask you amongst this eight subtype, which is the most commonest subtype? Number one question in exam. The answer is M2. M2 is one of the most common because out of 100, 30% is M2. Rest of all the thing is 70%. So most common M2. Number one question. Second question. Which AML subtype present with disseminated intravascular coagulation? Answer is M3. It is called acute promyelocytic leukemia, right? It is commonly present with the DIC, and this is the disease where you need to use ATRA, all trans retinoic acid with arsenic trioxide. It is a treatment of choice. ATRA is the drug of choice. This is very high hit question in exam. Second question, third question, fourth question. Amongst all subtype, which is the rare category of AML? Rare category is the AML M7, rare category. I probably, honestly speaking, in last 20 years of my hematology practice, I have not seen even a single patient. So rest of the doctors is difficult, no? Because it's my primary subject. Still, I did not seen it. So it's a
I know,
relatively extremely rare, right? So most common is this, most rare is this. DIC is present with this. What is the drug of choice? Is this, right? So there are lots of questions which we need to understand in the exam to clarify our thought process, right? So this is what this all sets of the questions are here, right? They had given best prognosis amongst all AML, which subtype, right? We already seen it. Let's break it. So AML M3, or its name is acute promyelocytic leukemia. Commonest AML is M2, 30% of the patient present with AML M2. DIC common in which AML? AML M3, APL, acute promyelocytic leukemia. How to categorize AML risk factor? So by total count, how the WBC is low or high? What is the cytogenetic of the patients, means chromosomal? What is the FIS test? Depends on that. You, stratify the risk factor, right? How to treat the high risk AML? So how high risk AML means which AML? Those who present with high WBC count, those who have FLT3 molecular test positive, right? These are the high risk fact patients from day one. So give the induction chemotherapy followed by bone marrow transplant is the treatment of choice. And what is ATRA? ATRA is all trans retinoic acid. It is a vitamin A derivatives, right? Which blocks the translocation of 15 and 17. You can say it's a targeted therapy like 922 translocation Philadelphia. Imatinib is the drug of choice. Same way, the translocation 1517, it's blocked by the ATRA, all trans, and it is used in AML. AML M3 is drug of choice. So these are the few important and very, very important MCQs. So already we all discussed this, how we treat it without seeing the answer. So I answered all 7 questions. So thank you very much all for your kind attentions. I have hundreds of more slides to discuss. So just stay tuned, stay with me, and do let me know for any help you need in hematology, oncology. I would be glad and happy. Before I end up my session, I would like to have a very quick feedback on the both the session. How did you enjoy it? Because we enjoyed a lot while presenting. So hopefully you you must also enjoy it. So what's the new learning? We have many slides. I have more than 500 slides for hematology because of my primary core expertise and area of interest, but I try to compile as per the DHA, HAD, MOH, OMSB and other international exam. Not going in detail, but still you need to know the basic things about things and many topics probably untouched by you and many fields hematology is complex subjects. So I try to make it easy. Yes. So before I end up my session, I would be glad and happy if you can spend 2 minutes and give your feedback. How did you enjoy both the class back to back? Yes, please. Anyone can feedback, no problem.
Absolutely great, sir. It's very informative.
Wonderful. So what did you learn, sir, today? What's the new learning?
It's a different type of leukemia, AML, ALL, CML, CLL.
Wonderful. Wonderful. Brilliant, sir. It's important. Still, it is, I mean, there are many questions, but we'll cover probably in the next time. Wonderful. Thank you very much for your feedback. Yes, Dr. Justin, Dr. M. Kavita, Rajesh Radhan, Ganiat Hassan, Lutfor, Mariam, Mifra, a lot of people in the class.
So the lecture was very interesting. You explained in a way that we can understand very well. You never get fed up of explaining, sir. It's your talent.
Great. Yes, anyone?
Very good
Yeah,
session,
thank
sir.
you.
The way you break down the facts about about leukemia it's so such a broad topic, and the way you break it down to make it so easy is just amazing. We can recollect it so fast from those points. So thank you so much for that, sir.
Wonderful, sir. Thank you very much for your kind feedback. Thank you very much. Last, Dr. Rajesh Radhan, how was your experience?
Thank you so much.
Yes, anyone? Yes.
I think
it
we
was
will
wonderful.
answer all leukemia questions. Thank you.
Yes, yes, I'll take it. I'll take it. I'll take it. Constraining time, sometime we'll make just leukemia class only, no
No, sir.
hematology,
I
only
meant
leukemia.
that we can answer all leukemia question with your excellent session today.
Wonderful. Yeah, I mean, common topics we covered, but we'll cover more in next session. So we need to touch the low platelet, high platelet, polycythemia, myelodysplastic syndrome, aplastic, multiple myeloma. There are a lot of things, but we'll probably catch up in the next class. So anyone last for the class today? Anyone last? Any last final feedback? Yes, Rajesh, would you like to speak anything?
So it was very knowledgeable, especially the last two questions, and it was very new to me regarding this leukemia because I have generally less idea about this subject. So it was very knowledgeable.
Wonderful. Thank you very much. And we have
And
many
the
videos. This is
subtypes
what
of
I was.
AML also, it was very informative regarding the subtypes of AML.
Wonderful. So what you can do, sir, those who are like feel weak in hematology, I have many 5, 10 big classes on the same our YouTube channel. That is, I was telling you in the initial, at least try to see one video a day. At least try to see one video a day from our collection. It's open access, fortunately. So you just get the glimpse of the experts' knowledge, right, which is like, I mean, compiled in a simpler way for the exam purpose or exam point of view. Otherwise you get thousands of video, but they are general, right? We are targeting only MCQ, how they and what they ask in exam. So that probably helps you a lot. So try to make habit before you go to bed, see at least one video, maybe hematology, oncology, cardiology. Lots of videos are there, and even believe me, if you do it that only na, your 80% course is covered, believe me. 80% course is covered because every time there is a new MCQ, new concept, new things. So just try to utilize our expertise. Thank you very much and see you in the next class. Enjoy your Sunday. Thank you.
Thank you, sir. Thank you.
Thank you very much.
Thank you.
Thank you very much.